Hello everyone. Today we will discuss about Turner syndrome. Turner syndrome is a chromosomal disorder affecting phenotypic females caused by total or partial loss of one X chromosome. It leads to short stature, gonadal dysgenesis, multisystem, and a genetic condition characterized by complete or partial monosomy of the X chromosome, 45X or mosaic variants. It results in estrogen deficiency and failure of normal sexual development. It occurs 1 in 2000 to 2500 live female births, and 99% of conception result in spontaneous abortion. There is no racial predilection, and mosaic variants form roughly 50% of the cases. Caused by meiotic non-disjunction or post-zygotic mitotic error, leads to loss of one X chromosome. A SHOX gene deletion results in short stature. Types can be monosomy, wherein there will be 45X with the loss of one chromosome, mosaicism, wherein there will be 45X or 46XX, and structural abnormalities in isochromosome as well as in ring chromosomes. Mostly sporadic due to random chromosomal non-distinction. There is no environmental or maternal age association with Turner syndrome. Rare familial causes due to parental X autosomal translocation. Paternal meiotic error, there will be loss of paternal X in 70 to 80% of the cases. Recurrence risk in families is extremely low. Coming to the pathophysiology, gonadal dysgenesis result in streak gonads, resulting in estrogen deficiency. Because of loss of SHOX gene, there will be short stature and multi-system involvement in cardiovascular, renal, skeletal, and endocrine. Clinical features include short stature, webbed neck and low hairline, shielded chest with widespread nipples, cubitus valgus, lymphedema of hands and feet in infancy. The systemic features include there will be primary amenorrhea and infertility in gonadal part, coarctation of aorta, bicuspid aortic valve, and hypertension in cardiovascular system, and horseshoe kidney and duplication in renal system. There will be hypothyroidism, obesity, and diabetes. And psychologically, they will have normal IQ, but they will have learning difficulties. So this is the typical stature of a Turner syndrome, where there will be short stature, webbing of the neck with a low posterior hairline, broad chest and widely spaced nipples, a coarctation of aorta and bicuspid aortic valve, cubitus valgus, pigmented nevi, streak ovaries, infertility due to primary amenorrhea, and peripheral lymphedema at birth. Differential diagnosis: Noonan syndrome with a similar phenotype but normal karyotype. MRKH syndrome, where there will be absent uterus and normal secondary sexual characteristics. Kallmann syndrome, where there will be hypogonadotropic hypogonadism with anosmia. Constitutional delay of puberty. Coming to the investigations, karyotyping confirms the diagnosis of 45X or mosaicism. Hormonal profile, there will be increased FSH and LH but decreased estrogen. Ultrasound pelvis reveals a streak gonads and small uterus. Echocardiography, there will be coarctation of aorta. Renal ultrasound, there will be anomaly. Thyroid and glucose screening will be present. Coming to the management, growth hormone therapy in early childhood, estrogen therapy at puberty for secondary sexual characteristics, adding progesterone later to induce menstruation, IVF donor with donor oocytes for fertility, lifelong follow for cardiac, renal, metabolic, and psychological health. Short stature, if untreated, is a known complication, followed by osteoporosis from estrogen deficiency, hypertension and heart diseases, diabetes and hypothyroidism, infertility, and psychological distress. It is good with early diagnosis and hormone therapy. The prognosis is better. Normal intelligence and near normal life expectancy. Regular monitoring improves the quality of life. So, to summarize, Turner syndrome is a chromosomal disorder in female due to complete or partial absence of one X chromosome, usually 45XO or mosaic variants. It occurs in 1 in 2500 live births. 99% of those affected by it are aborted spontaneously after conception. Monosomy X, mosaicism, structural X abnormalities, SHOX gene deletion result in short stature or the genetic basis. The mostly sporadic, no link to maternal age or rare familial cases may involve. Pathophysiology involves gonadal dysgenesis resulting in estrogen deficiency. Loss of SHOS genes result in skeletal abnormalities and multi-system involvement. So there will be short stature, webbed neck, low hairline, shielded chest, streak gonads, primary amenorrhea, infertility, coarctation of aorta, and horseshoe kidney. Investigations, karyotyping and hormonal profile, ultrasound pelvis, cardiac and renal imaging are required. Management involves growth hormone therapy for height, estrogen replacement for puberty, progesterone for menstruation, IVF with the donor oocytes for fertility. Complications include osteoporosis, hypertension, diabetes, infertility, psychosocial issues. Prognosis good with early hormone therapy and multidisciplinary care, normal intelligence with near normal life expectancy. So I hope you have learned from this presentation. Thank you for watching the video.